We'll be getting started in a few minutes. Once again, for everybody just recently joining, my name is Jennifer. I'll be the moderator for the event. I'm a customer success manager here at Kindbody. So excited, so proud to be here. The goal of the event today is to teach each one of you how to advocate for your health, specifically your reproductive health. This is a safe space. You can post your questions, your comments in the chat. We'll be answering and addressing your questions throughout the event. We'll be starting shortly, and again, this is a safe space. Feel free to leave those comments and questions down below. We'll be addressing them during and after the event, so stay tuned. So we'll be getting started, and just as you can see here, the title of the event is Race and Fertility. We're shedding light on racial disparities in fertility, empowering Black and minority individuals to take control of their reproductive health. And we're gonna get started right now. So we're gonna move to the next slide. So I'll go over briefly the agenda so you guys know exactly what we're gonna discuss today. The first part will be covered by Dr. Nicole Browne, and she's gonna discuss the clinical reasons that lead to an increased risk of fertility and fertility education. Part 2 will be covered by Dr. Juliet Nevins, and she'll be discussing in depth the socioeconomic barriers to attaining equal reproductive health and fertility care. The final part of our discussion today will be led by Reverend Dr. Stacy Edwards Dunn, and she'll be discussing how we can empower Black and minority individuals to take control of their reproductive health. To conclude, I'll just be discussing more information about the types of cycles, pricing here at Kindbody, and then we'll have an open floor where you can ask your questions and have your comments addressed as well. Next slide, please. These are our panelists. We have our reproductive endocrinologist, Dr. Nicole Browne, OBGYN, Dr. Juliet Nevins, Reverend Dr. Stacy Edwards Dunn, and myself, Jennifer Woods, Customer Success Manager here at Kindbody. Next slide, please. Reverend Stacey, can you please do that?
Good afternoon, everyone. My name is Reverend Dr. Stacy Edwards Dunn. I'm the founder and president of Fertility for Colored Girls, as well as the church administrator and executive pastor at Trinity United Church of Christ. We are absolutely hippopotamus happy that you have joined us on this day. And I just want to open up talking about that as a group, persons of African American or African descent experience disparities with chronic conditions and access to care and preventative screenings, along with mental health. And fertility and reproductive health is among these conditions. Oftentimes, many people do not realize it, but because particularly in the African American community or in our society, people do not really realize that Black women in particular are struggling with infertility. But the reality is that this is a real issue, a huge giant that women of color, women who have been kissed by nature's son are dealing with on an everyday basis. Next slide.
And I'm Dr. Nicole Browne. I'm a reproductive endocrinologist and infertility specialist with Kindbody, New York. And I'm so humbled to be a part of today's conversation on race and fertility with such an incredible group of women. And this talk has made me realize how vital a role I play in making sure that all women, regardless of resources, are able to fulfill their dreams of starting a family. So thank you. So our talk today is on race and fertility, and there are clinical disparities in infertility. Healthcare disparities in minority populations are not new, but more awareness to this growing disparity has been brought to our attention because of the growing COVID-19 pandemic and recent protests. Unfortunately, even access to fertility care and to treatment is not immune from this growing health disparities in underrepresented minority populations. We know that Black women tend to experience infertility more than white women. And when Black women do seek access to fertility care, they tend to have lower success rates compared to their white counterparts. Some of the lower success rates seen in Black women compared to white women who seek fertility treatment include lower implantation rates and lower clinical pregnancy rates and increased miscarriage rates. Now, the differences in outcomes between these two groups, it's really unknown and understudied, but we believe that these differences may be due to both biological and to behavioral factors. One potential biological risk factor that can explain poor reproductive outcomes in Black women is uterine fibroids. And we know that uterine fibroids affect 20 to 50% of reproductive age women. And for some reason, they disproportionately affect Black women more. Uterine fibroids are just benign growths of smooth muscle cells in the wall of the uterus, and they can vary in location and in size. And when Black women do present for treatment due to a symptomatic fibroid uterus, or if they're trying to conceive, they tend to present at a later stage of their development. And as I mentioned before, fibroids can have detrimental effects on reproductive outcomes and put one at greater risk for miscarriages, preterm labor and delivery, and possibly even the need for operative deliveries and a hysterectomy. Behavioral risk factors can also explain racial disparities that we see in fertility. We know that diet and lifestyle can actually play a significant role in our ability to get pregnant and to stay pregnant. And for some women, especially for obese and fertile women, and for some women who have an underlying hormonal condition such as polycystic ovarian syndrome, sometimes if you just encourage these women to lose 5 to 10% of their body weight, they can actually start to ovulate more regularly, and you can actually lower their chances of a miscarriage. Mental health and stress can also affect fertility outcomes. For some individuals and couples who are infertile, infertility can actually pose a life crisis, and it can affect their overall well-being and stability. And we know that for some, infertility can be a stigma. Sometimes it's just something that you don't talk about. You feel uncomfortable confiding in friends or family members what it is you've been going through. It can even prevent you from seeking care. And as we know, can even result in psychological disorders such as anxiety and depression, which can have adverse effects on fertility. As I began with, disparities exist in fertility care and in treatment. And even when there is access to fertility care, Black women and underrepresented minorities just don't seek it. And there's a variety of reasons for this. It's just not convenient. It's hard to take time off from work to come in for frequent monitoring. It may not be affordable, especially when you're making a decision between paying the light bill or getting access to fertility care. It just may not be doable at that moment. There's also a cultural emphasis sometimes in some minority groups on privacy. Again, we just don't talk about these things, and a stigma associated with infertility, which prevents many minority women from being proactive in seeking access to care. So what can we do? Well, at Kindbody, we pride ourselves on acknowledging that the sooner a woman has access to information about her fertility, the more options she will have. And we believe by educating women through our fertility education seminars like this one, and even through fertility assessment, we're able to give women as much information about their ovarian reserve as possible. A fertility assessment with us at Kindbody involves an ultrasound to take a look at, to do an egg count, and also a blood test called AMH that also gives us a good sense of ovarian reserve. And so for us, all women are born with a set number of eggs, and either we're going to use these eggs or we're going to lose them. And so egg quantity definitely plays a big part in our ability to get pregnant, but so does age. And so for us, our fertility starts to level off at age 35. By age 38 now, we give all women the diagnosis of diminished ovarian reserve, even if they have plenty of eggs. By 40 to 42, I'm usually telling most infertile women that they have a 5 to 15% chance of taking home a baby using their own eggs. At 43, a less than 1% chance of getting pregnant using your own eggs. And then at 44, 45, a 0% chance. I want everyone to think today of ovarian reserve as a mathematical equation. So you have to think of it as egg quantity plus egg quality. Again, it's always good to know that you have the quantity, but what matters most is quality. Quality trumps quantity, and this is where our age comes into play. So when I meet with an individual or a couple looking to conceive, there's always 4 things that I need to know. I want to know that there are plenty of eggs, plenty of sperm, that at least one fallopian tube is open, because this is where the egg meets with the sperm for fertilization to happen, and that there's absolutely nothing inside of the uterus that would compete with a baby for space, like a polyp or a fibroid. And so for those who are trying now to conceive naturally, it's important to remember that there's a small window of time that we're most fertile. And this varies for every woman. And so when you have very regular cycles, you have to try to capture this fertile window, which is about 5 days in the cycle, to try to conceive. And you can time this either using apps, ovulation predictor kits, or come into the office for blood work and monitoring so that we can tell you the exact time to have intercourse. So what does it mean to be infertile? Well, it's a diagnosis that we give to someone who's been trying consistently for at least a year to conceive on their own, but they've been unable to. For some women, you can't use that definition. And so if you're over the age of 35, or if you have a history of irregular cycles, if you've been exposed to chemotherapy or radiation, or if you've had surgery to remove an ovary, you need to come in sooner to undergo a fertility evaluation. And this quote I got from Reverend Stacey, and it's a wonderful, marvelous quote. Paths to parenthood are all different, but they're not deficient. And thank you for sharing that, because it's so true. Sometimes natural conception isn't enough to help us be able to start our families. And then we need options. And so some of these treatment options can be done medicated or natural. Artificial inseminations using donor sperm or partner sperm, in vitro fertilization, which is actually our most aggressive form of fertility treatment that we offer. Again, it can be done using your own eggs, your partner sperm, or with donor egg or donor sperm if needed. And then there are third-party options where we can use donor eggs to help a couple conceive, or an individual, sperm donors, or even surrogates to carry a pregnancy. In the end, the most important part here is we have options. Briefly, artificial insemination is where we inseminate the female partner with washed semen, and everything happens in vivo in the body to make conception happen. In vitro fertilization, again, is the most aggressive form of fertility treatment that we offer. Okay, and this is where things happen outside of the body in order to help an individual or couple be able to fulfill their dreams of starting their family. And sometimes an individual may not be ready to start their family, but they want the option of being able to start their family at a later time. And this is where egg freezing or even embryo freezing comes into play. And all of these things we offer here at Kindbody.
Good afternoon. My name is Dr. Juliet Dennis. I founded and I basically write blogs on belowthebellybutton.com. I'm an OBGYN. I also do a lot of population health work as a clinical solutions medical director for Aetna. In addition, I went through IUI, I went through IVF, I had a myomectomy. So this topic is not only very important, but it's very near and dear to my heart. So before I go on to talk about barriers, I do have a question for Dr. Nicole, and I'm asking hopefully for the benefit of the audience in terms of myomectomy, because I remember we got a lot of these questions when I was seeing patients in the office. And that's basically the who, how, and when of myomectomy. Should you go see your infertility doctor to do the surgery? Should you have an open procedure versus a laparoscopic procedure? And how close to your intended or hoped for date of conception should you have this procedure done?
Sure. first of all, the myomectomy can be done with either a reproductive endocrinologist or with your OBGYN. I can tell you how many times I've done a myomectomy with my OBGYN colleagues, and we're all trained to do it the same way. The most important thing is that you want to preserve the integrity of the lining of the uterus to try to minimize the risk for scarring of the uterine cavity. In terms of an open versus a laparoscopic myomectomy, that's going to depend on the number of fibroids, the size of the fibroids, and just how deep into the wall of the uterus those fibroids are. And so that decision should be made in conjunction with your treating provider.
Wonderful, thank you. I'm going to go on to the next section. I just have some short comments to make, and hopefully that will engender discussion among the panelists and certainly questions from you guys out there in Zoom land. You know, my work at this point in my life is about educating women and the people who love them, and it's about thinking about what happens between the home and the doctor's office. So to that end, please go to the next slide. So the picture on this slide is obviously the cover of a Time magazine that came in my mailbox about 3 weeks ago. And it was very profound. It had a really, it gave me, you know, it made me pause, because it really sort of visually described what's happening in our world today around the protests, health disparities that are a function of socioeconomic disparities. And certainly we can extrapolate the meaning of this picture to what's happening around infertility and the lack of resources for Black women and women in other minority groups. I want to sort of reiterate some of the things that Dr. Nicole have already touched on. This whole category, however, is about socioeconomic determinants of health, starting with health literacy, understanding what's happening physiologically and biologically, your risk for infertility if you smoke, and that obviously is a function of your community and your exposure to cigarette smoke in terms of the carcinogen and in terms of your likelihood of becoming a smoker. Your increased risk of being exposed to a sexually transmitted infection, understanding about age-related infertility, right? I still have people who tell me that as long as you're having a period, they can have a baby. Not true, right, Dr. Nicole?
Exactly.
Exactly.
Not true.
Not true. The issue of obesity, you know, in America, about 60% of Americans and therefore women are considered obese. So these are all factors that are more prevalent in areas, in urban centers, but certainly across the African American and not just, and it's not specific to African American communities, but certainly other communities, other minority communities as well. The other issue with respect to socioeconomic determinants of health is a function of your religious beliefs and cultural barriers. And I'll give you just a very, very quick story of what I'm talking about. My dad had COVID-19. He was taken via an ambulance to a hospital in his neighborhood. It was not a well-resourced neighborhood, and he literally almost died. Now, he had been admitted to that hospital in prior years, and at one point I met an Asian American physician who said to me, because I lamented that he wasn't willing to leave the community and take my advice, his daughter, and go someplace else, you know, a better resource facility who could potentially provide better care. He wouldn't leave. He felt comfortable where he was, but that hospital was not equipped to deal with the acuity of his problems. This Asian American physician said to me, I understand. My parents are Chinese. They live in Chinatown. Chinatown has not necessarily always been good to them, but that is their community. That's where they live, and that's where they will continue to seek care. So across this sort of racial and cultural see, if you will, right, is a similar sort of experience in terms of minority groups not being willing to leave their communities to seek care elsewhere. And we'll see why that's important. Next slide. So there was a recent study in Health Affairs Journal which talked about this very concept, this very phenomenon, whereby it's not just a function of your race or ethnicity. It's a function of where the resources are. So independent of being Black, female, Arab, Asian, whatever your ethnicity or your group is, if you cannot or are unwilling to leave, your area to go to another place, that in and of itself is a barrier. That the hospitals in the communities are not necessarily equipped to and are not aligned with the acuity of the diseases that that community presents with. And that is a function of the segregation, institutionalized, that has occurred over centuries around housing. So that is where we talk about, socioeconomic determinants of health, and where other institutions, education, housing, subsequently impact your health outcome. The other very important thing we need to talk about is money, right? We didn't have Kindbody 10 years ago. There was no, how old is Kindbody? Jennifer, how old is Kindbody? You're on mute, Jennifer. You're still on mute. How old is
Hear me now?
Yes.
Sorry about that. 2018, we came into existence.
There you go. So we did not have a Kindbody. And we didn't have the theme in terms of providing specific care to women potentially in their own communities. And I believe that this is where this organization is necessarily heading. But your inability to leave, as I was saying before, whether it's having a car, having the time is important, but also in terms of the cost of infertility and coverage by insurance companies. Now, there's a new law many of you may or may not be aware of, and certainly not all of you from the audience live in New York, but there's a mandate now that requires employers who have more than 100 employees to cover up to 3 cycles of IVF. That still omits a significant portion of women families who may want to use IVF services. So a fixed price is very, very helpful when one is going down this road and potentially going alone in terms of your financial resources. Next slide, please. Dr. Nicole has already sort of mentioned some of these statistics in terms of the disparities. Black and non-Hispanic women are more likely to report infertility, but are 20% less likely to receive infertility care. On the other hand, if you take women between 15 and 44 years old, 85% of those cycles or the treatments are not for Black non-Hispanic women. They are by white women. In fact, only 4.6% of the cycles are for Black non-Hispanic women. So that's a huge disparity in terms of need and the availability of this service. Next slide. So layered on top of all of this issue, we have the disparity, we have socioeconomic determinants of health, and that involves housing, health, education, and including in that is health education. There is racism that impacts the outcome of care. And it's very systemic. So we look at sickle cell disease, for example, which is 3 times more common and prevalent in this country than cystic fibrosis, yet the latter receives about 11 times more funding. In 1972, most of you may be aware of the Tuskegee syphilis experiment, where a cohort of Black men who were known to have syphilis were deliberately not treated because the U.S. Public Health Service wanted to see what would happen. They wanted to learn about the prognosis of untreated syphilis, and there's a lot of information that was had from that, in that it could, cause neurological damage and the like. So these are the things that occur that are built into the system that are cemented and deliberate barriers, and that create and sustain that disparity among communities. And then once you get in the door, once you get into the office, you do have stereotypes that impact what the doctor actually recommends to that patient. And we see that this played out in other areas, diabetes, heart disease, in terms of people who are referred for transplant, the types of medications that are prescribed and the like. And infertility there's no different there. And I will tell you that as an OBGYN, I worked for a federally qualified healthcare system, uninsured and underinsured women. I did what I could in terms of working them up for their infertility, but I could go no further. We did not have an IVF person that I knew about in the neighborhood. I knew that this patient did not have insurance, and I was kind of stumped. I was aware as a Black person that this is a very private, but however traumatic in terms of the cultural affiliations that I'm dealing with. Being a mother is very important in many, many of these cultures that we're talking about. But I did not necessarily prescribe them an infertility doctor, only because they knew that they couldn't afford and it wasn't available. But those kinds of assumptions are made even without any sort of forethought or consideration of the consequences for the patient, or any attempt at any sort of workaround. At the very least, one should be provided the information that you need, whether or not you're able to follow through. And then there's just the depiction of Black women being able to sort of make babies that were hyperfertile. This is something that was brought to light, by Reverend Stacey, in terms of the stereotypes that exist out there around Black women and our procreative ability. So that also, in and of itself, will pose a barrier to getting the care, getting the advice that one needs to move forward. So I'll stop there for any comments, and if none, we'll move on to Reverend Stacey.
Any comments? Questions, comments will be addressed as we move forward.
Got it.
You can go ahead.
Hi, again, I'm Reverend Stacey Edwards Dunn, and I have been charged with talking about how we can empower Black and minority individuals to take control of their reproductive health. And I think the best way for me to start my section of this conversation is to share a little bit about my story. I, like many of women in the African American community, made a decision to, first of all, always wanted to be a mother. And I always knew that since I was a very, very little girl. Most of the people around me will tell you that know me that I always mothered. I mothered my friends. I mothered my nieces and nephews. I mothered everyone. And so from a very young age, I always knew that I wanted to be a mother. But I also dealt with some of the cultural, even insensitivities that we would even hear in the Black community, particularly as women, don't be fast, don't get, make sure you're not being fast, don't get pregnant. Everybody was telling me not to get pregnant, but they never told me what I needed to do to prepare to get pregnant. And also, as you know, in the African American community, it is a huge myth. Most people think that women of African descent, that we are hyperfertile or we are baby making machines. And much of that comes from many of the breeding myths that took place, particularly in slavery, because we were seen particularly as more as machines and not human. And we were brought here to simply be breeders and not seen as humans or as a people. And so much of that has shaped much of how people see us as a people. And so growing up in my community, and I know in many of our communities, infertility was not a conversation in my household nor in my community. And so my parents, like many of parents that I have heard, told me to go to school, make sure I establish my career, and I find me a good old husband before I decide to become a parent. And I did exactly that. I put everything off to establish my career and to make sure I found me a good husband. And so at the age of 37, I finally ended up getting married. And I would find the fertility issues that I never thought that I would have, because I thought, just like everybody told me, that when I was ready, I was going to be able to have a baby. But I find out very differently. And so in 2007, not too long after we got married, we began to forge forward to try to become a parent, found that to become parents, and would find out that both of us had male factor and female factor infertility. And so our journey lasted for about 7 years. I was, of course, in shock. And not only as a Black woman, but also as a Black woman who was clergy, I really struggled, and I lived with some shame. One, because I couldn't get pregnant when I wanted to, but also I was a Black woman who was clergy, who was praying for all of these other people and was getting prayers through for them to have children, but I couldn't even get one through for myself. And so as I began to encounter women, particularly in my counseling suite at church, they would come to me. God was sending these women and couples to me who were struggling with infertility, who had no idea that I was struggling. They were seeking out a space, a safe space to talk about what they were going through. And because there was no place for them to go in their churches, in their communities, and even they didn't even feel comfortable talking to girlfriends about what they were going through. And so as I continued to encounter these women and couples, and also continue to have my own journey as well, God led me to start the organization Fertility for Colored Girls. Fertility for Colored Girls is an organization that we declare is the national organization for African-American women and women of color who are struggling with infertility and seeking to build the families of their dreams. It is an organization where our mission is to provide education, awareness, support, and encouragement for Black women and couples in our community, and to raise awareness, because again, this is not a conversation that we're talking about in our communities, let alone that the world was really, or is still really not talking about. And so in 2013, in March 8th of 2013, when we launched Fertility for Colored Girls, actually at that time I was in my sixth year of my infertility journey. I had just had my first miscarriage. I was struggling. I was in a very dark place. I wasn't going through any more treatments. And I should say it was also my sixth in vitro. I was in a very, very dark place. And so at that particular time, I had made the decision to even move forward with adoption. My husband stopped and said, "Hey, let's pause." And he said, "I think if we do it one more time, we will become parents." And so we tried in vitro for the last time. In 2013, I took 30 days off of work. And on January 2nd of 2014 at 2:30 p.m., I received a call from the doctor's office. The dog stopped in the track, and I had about 5 or 6 people in the background screaming that I was pregnant with my now 5.5-year-old daughter, Shiloh Lupita Iman Dunn, telling us that they had prayed for us too for this particular moment, because they too wanted us pregnant just as much as we wanted to become parents. And so Fertility for Colored Girls has really become a labor of love for me. It is a part of my life's mission to help women and couples who I believe, who know at the deepest depths of their hearts that God has called them to be parents, to help them to become parents through some path, or through the path that God has defined for them. As Dr. Nicole said earlier, that for me, none of those paths are deficient. The path is just different, but God has a path for each and every one of us to become parents. And so since March 8th of 2013, Fertility for Colored Girls has been blessed to open up 13 locations. We will be in 20 locations by the end of this year. You will see, yes, we do have a New York chapter. I see you, sis, writing us. And you can see some of those chapters that I've already listed in the chat. But we will be opening 7 more chapters by the end of this year. The organization provides support groups. We normally meet live, but as you know, due to the pandemic, we have been meeting virtually. So if you are interested in joining one of our support groups virtually right now, we would love to get you connected. Every Monday morning, we gather at 7 a.m. Central, 8 p.m. Eastern, it's 5 a.m. Pacific to pray over women. We have helped more than 200 women become parents through, the support that we provide. In addition, we have relationships and partnerships with doctors all over this country, including we have been blessed to have now a beautiful relationship with Kindbody as well. And so as a result of this new relationship with Kindbody, just in a few weeks that we have known them, have proved to be very sincere and genuine about caring for not only women of African descent or who have been kissed by nature's son, but women of all ethnicities. They are not just about making sure that we have the financial resources to move forward with building our families. They are also very interested in helping to educate, providing holistic education and support to women of African descent, as well as all women of all ethnicities. And so I think that's the beauty about them that I'm learning. Again, they are very genuine, they are very open, they are very personal. And I should put a pin there and say to you, and particularly as African-American women, I know that one of the challenges for many of us is that we have a mistrust in the medical system. And we don't really trust a lot of doctors because of our experience and some of the things that have happened in history, and even some of the things that some doctors have said to us. And so that's why it's very, very important that you advocate for yourself, that you make sure that you have the tools in your toolbox to be able to advocate for yourself and ask the right questions, and also that you have other people around you to provide you some information as you go into these doctors and you meet with these various fertility clinics, and that you listen to your soul and to your body. If you feel like something, if you feel triggered or you feel like something is not right with that particular doctor, but you want to make sure that this doctor is right for you. And I am convinced that Kindbody has some very great doctors, and they are going to usher you through this process and treat you rightly if you make the decision to work with them as well. So we have been blessed to, Kindbody is an amazing organization, as I stated, a fertility clinic that has become committed and wants everyone to know that not only Black lives matter, but also Black infertility or Black fertility matters. And so what they have done is that they have made an initial donation of $50,000 that will go toward covering fertility cycles such as IUI, IVF, egg freezing for those who meet the eligibility requirements. Grantees will obtain services at Kindbody Clinic in New York, Los Angeles, or San Francisco, and you can apply for that grant at www.fertilityforcoloredgirls.org. And so please check the Fertility for Colored Girls website. You have until September 1st, 2020, and we will we will notify those persons who have been awarded the grant by September 15th, so that you can redeem your cycles or whatever service by January 1st, 2020. And so again, we are just so excited that you all are a part. We want to encourage you to never give up hope, and just know that you are not alone in this process. Not only do you have Kindbody, you have Fertility for Colored Girls that is here walking by your side, here to support you every step of the way and hold your arms up during this journey. God bless you.
Awesome. Thank you for that. Thank you, Reverend Stacey. Reverend Stacey, thank you so much for sharing your story, your testimony. That was amazing. I hope you all feel encouraged and motivated. What a wonderful discussion we just had with awesome and amazing panelists. It's so important to take control of your health. Knowledge really is key. I'm going to offer further information regarding Kindbody treatment costs. So today, since all of you guys have attended our event, there is a special code that we want to leave you with. If you are interested in booking an appointment with us here at Kindbody, you would go to our website, kindbody.com/book, to schedule an appointment with us. And when you do go to our website to schedule that appointment, you'll use the promo code here, BFM2020. And when you book that appointment, whether you want to do a fertility assessment, an egg freezing cycle, or IVF cycle, you'll start off with an assessment first. You'll apply that code and it'll get you a discount that you see here. So when you come to Kindbody, all cycles start off with a fertility assessment. So as you see in front of you, the fertility assessment, the normal price is $300. With the BFM 2020 code, that drops it down to $150. We do accept insurance. We're on board with most major insurance carriers. And if you have questions about coverage, feel free to contact us through email, which is listed below, navigator@kindbody.com. Can we go to the next slide, please? As I just mentioned, insurance, we do accept major carriers: Aetna, Anthem, Blue Cross Blue Shield, Cigna, Empire, Multiplan, Oxford. We'll go into detail when you email us, and we have a billing team that we work closely with to offer you more information. At this point in time, we're going to open the floor or the chat for questions. We have our team here working with questions and answer, but anything that hasn't been addressed, we'll work through right now. We'll present the questions to our panelists. So I'm going to sort through the questions right now and we'll go through them. Is there anything outstanding? Let's take a look. And you can continue to ask the questions in the chat and we'll go through them right away.
Well, I have a question for Reverend Stacey. I really want to hear your comments around this, and it's about, and I ask you because this was my journey, right? I grew up in East New York, had to be a doctor, was told don't get pregnant, just focus on your schoolwork, and then I looked up. Yes, I was a physician, but I was also 38. And I went to an alumni event a few years back, and someone said that she had asked an older person if there was one thing that I should do if I could do this again, what would that be? And the older alumni said, plan for your family in the same way you plan for your career. And it made so much sense because we think about where we want to live, our degree, the job that we want, and we just assume, and Dr. Nicole, I don't know if you get this a lot. If it happens, it happens. Patients say that a lot, right? But I'm curious as to how you counsel women in terms of taking control and navigating contemporaneous goals that sometimes compete for your time.
You know, Dr. Juliet, I grew up the same way. You know, my parents told me to focus on my schoolwork, and, you know, make sure that I make something of myself. And so there wasn't much conversation about starting a family. It was always about doing well and just making sure I end up with a good job and doing something that I love to do. I think this goes back to more cultural awareness with Black parents, Black families, where we need to be more open about talking about, you know, our dreams of wanting to have a family later on in life. I know it was something that my family didn't talk about when I was growing up. Again, the goal was not to get pregnant when I was younger and just focus on school. I think we just have to be more open as a community.
Yeah, yeah.
I hope you can hear the lawnmower behind me that just decided to mow the lawn.
No,
but for me, what I normally do is I keep they are. And I believe the reality is for many of us, and particularly in the African American community, is that most of us have been educated, even from a faith perspective, from a very patriarchal and hierarchical and a very fundamental theological perspective. So for me, there's a lot of when I'm try to meet them to what they have to say, then get them on the path, not in which their parents defined for them, but the original plan in which they believe God has defined for them. Because the reality is that us, including our parents and even us, we have some particular plans that we perceive are for us. But he says that I know the plans that I have for God, or to hurt you. And so if you get persons that I provide counseling for to focus on what God has, the plan that God has for them. And that plan may be very different from what our parents think it's supposed to be. That plan may be very different from what our Sunday school told us that it was teachers, so it was supposed to be. That plan may be very different from even what a friend or what a friend's plan is for their lives. And so I try to get them to focus in on that and to live their own life based upon the God that created them, so that they can walk into the path, again, may be different, but not deficient, so that they can walk into their purpose. And so I don't shame anyone. I don't critique anyone, because I'm not the God of their lives. But they have a God who has created them and that has defined a path and a purpose for them before the creations of this world. And so that's how I counsel women. Because even for me, I come from a very, very fundamental background. My father is a pastor. I'm a PK. And so I too was told just what you women were told as well, right? And I lived into that. And I even thought about this morning. I said, I wonder what my life would have been if I would have taken a different path. Number one, I wouldn't have the beautiful daughter that I probably have right now. But what I have come to learn, even in my 7-year journey, that God used it to prepare me. So one, I could be the mother that I am to this particular and specific special child that God had for me, but also so that I can birth something even greater that would impact women all over this nation. So too might give birth and bring life into this world across the world. That's how I provide counseling to women.
One of the things I think is really, and Jennifer, you can cut me off whenever you're ready to ask questions that are from the audience. But one of the things I think that has changed culturally is our focus on, to use your word, Reverend Stacey, preparation. And even if you're not at the point in your life chronologically when you're ready, but just thinking about it in terms of at least having a consultation with, a Dr. Nicole, in terms of what do I need to know, what I need to think about, is it a good time, to start doing, egg freezing, just so you have literacy and understanding over biological facts around, what's possible today or 5 years from now. And I think just consultations, I think, are good. And I think we're embarking and we're in a period where people are asking questions. Knowledge in terms of medicine is not necessarily owned by physicians anymore. And I think people are now sort of more willing to ask questions, even if they're not willing to undergo any intervention or need any intervention at this juncture.
If they're questioning it,
wonderful. Mm-hmm.
If they're questioning it, then I think they need to come in and don't hesitate. There's a reason why you're questioning it. Come in, get advice, do the testing. We may find something that needs to be acted upon sooner than later. I can't tell you how many times I see so much regret because the questions were just put on hold because there were other things that needed to be looked into. If you're questioning it, come on in.
Right. And the other thing I wanted to say is, being aware of the barriers is important so that you can figure out how to get around them. It's not so that you can don't continue to allow them to be barriers for you. If you don't have an infertility specialist in your neighborhood, then, find a way, to get to a Kindbody or to get to someone else. And I just don't think people are aware of their community and whether or not it's well resourced or not. That's just something that you need to sort of stop and look around and say, hey, that's not there, you know, and start looking for other resources where you can get your questions answered and get the care that you're looking for.
Good point. You know, I think now with more telemedicine and virtual consult appointments, I'm hoping that helps with some of the barriers to care. But again, there are different ways to get access to us.
Right. The financial barriers, I will say, are real. I mean, IVF is anywhere from $10,000 to $20,000. You educate me and inform me if I'm wrong. And sometimes you walk into the office and you don't even know what you're going to expect in terms of a bill at the end. So having defined pricing at the beginning is also a nice feature that's also very welcomed in this space.
Thank you so much for that information. So I have two questions. One is a FAQ that we always see. So I just wanted to bring it to the panel, particularly our physicians. One that states, I've been on birth control for over 15 years. Will this impact my fertility? How should we advise our patients?
No, but I would still come in to do a fertility assessment. Sometimes, especially when you've been on the birth control pill for a long period of time, it can overly suppress the ovaries. I would come into the office, do a fertility assessment. Let's take a look at those visible follicles in the ovaries, get an AMH blood test, just to make sure that everything is fine. I think it would give you some peace of mind.
Thank you. The second one, it stays here. If I want a donor egg from an African-American woman, is that an issue when I request something that particular? Is that something that we can request?
No issue here. Again, like Reverend Stacey said, none of these paths are deficient.
All right. We're still going through some questions. Let's see.
And I think in light of the George Floyd killing, the protests, attention being brought to institutionalized racism, to healthcare disparities, I think it's important. And I think there are lots of, we're pivoting in terms of the messaging around these issues. And you know, we know about the stereotypes, I don't think a lot of people, I don't think even Black people are aware that they own these stereotypes and they repeat them, right? I have a friend who's an attorney who insisted that her great-great aunt or whoever had a baby when she was 55, so she's not worried. So I think the stereotypes are out there, the beliefs are out there, but you know, the narrative that we can just pump out 6 babies whenever we want to, how do we fix that? In terms of a population, yes, we can educate people one-on-one, but you know, there's lots on the news. We're bringing light to disparities in other areas. You know, what do we do with respect to infertility in this cohort of people?
I just think that we have to continue again to educate in platforms such as this, as well as, you know, whether the news media, every time we get an opportunity to talk about it and talk about and deal with those stereotypes, we have to do it. It took a long time for us to get here, and it's going to be a process in deconstructing and reconstructing, you know, the real information about Black women and fertility and reproductive health, as well as Black men. And so for me, I think that that's it's going to be key. Every time we get an opportunity, we have to raise our voices. And that's not only us who are on a part of this panel, that's also the women who are also a part of this, that we move beyond our shame and we understand that infertility is not who we are. And we raise our voices and share our stories, because there's power in our stories. Stories heal, stories reframe, stories give hope. And so for me, I think that's very, very important. I want to also say I saw someone on the chat who was talking about, you know, in as much as, you know, we have all of these issues that cause us to have infertility. In the Black community, there's an also for women, particularly that are heterosexual, there's another issue that has created infertility for some of us, we feel, which is some women feel they're not married. And so the reality is, and they're like, what do I do at 40? Someone just posted it even after we made that decision. What if I want to be a mother by choice? Is it bad? No, it's not bad. No, it's not bad. And we want you to know that today. We don't want you to have any regrets. If you believe God has called you to be a mother, whether you are married, unmarried, LGBTQ, trans, go for it. We don't want you to have any regrets. If you know, and if you believe that it's time, move forward. Take advantage of the resources around you. See your doctor, whether it's your OBGYN or a fertility clinic, and have some conversation about what you need to do so that you can become a parent, or if it's adoption or whatever it may be. There are all types of options, and this is your life. And you only get one life, and this is not a dress rehearsal. So if you want to be a parent, we want you to forge forward and do what you need to do so that you can become a parent. 40 is not too late. So there is still time. And so we want to really encourage you today and affirm you and know that you're worth it, that you deserve it, that you are enough and you are able, and that God will make provision for you if you really believe that this is what God has called you to do.
Reverend Stacey, I'm going to cry.
I know.
I'm going to cry because I am a single mother by choice, and I made the decision because a patient who was the daughter of a pastor gave me permission to do that. Mm-hmm. I'm deadly serious. I was so depressed. I was getting older. I loved being a doctor, but it was hard delivering those babies and feeling like I was never going to be in that bed. I was never going to be the one pushing. And she came in. She got a donor sperm from, I don't know where, some other race, just to affirm Dr. Nicole's comments about sort of getting either the egg or the sperm from, a viable candidate. But she said that her father, a pastor, said that to her, that you don't have to be married to be a mother. And because he said that to her, she went and she became a mom using donor sperm. And I was so fascinated by her journey. And she spoke specifically to me and said, Dr. Nevins, you can do it too. And so I'm literally about to cry because you just took me back to that moment when I decided to sort of move forward, because I just felt like my life was really incomplete. So yeah, I mean, I don't think we can leave out sort of the spiritual, emotional part of this journey. And I think, Dr. Nicole, you, and I think all three of us, this whole drive to succeed, sort of sometimes it blocks out everything else. And we do need our families, our moms, whoever, to give us permission to think of our lives in more holistic ways. But it's understandable, right? They want us to succeed. My parents were immigrants. They're here because they want you to move two or three rungs up the ladder. And that's their focus. And that's the focus they have sort of imbued in their children.
I just want to say really quick to that, and thank you so much, Dr. Nevins, for sharing that. And I think even from a spiritual and a biblical perspective, most of us have been educated wrongly. Because if we would look at the real stories of the text, and particularly even when we talk about Jesus' mother was a young teenage mother who was pregnant as an unmarried woman. She got pregnant, and not by Joseph. I suggest that when Jesus' mother got pregnant, it was the first divine intrauterine insemination, as she was pregnant by God. Joseph was an adoptive father. And so let's be honest and real about that. Really, Mary, if we had to be, it's almost like she got pregnant by a donor, which was God. God was her father. And so we have to be honest, and we have to really interrogate the text very, very differently so that we can begin to see ourselves and not only allow people to give us permission, but we give ourselves permission through God to say, hey, I'm called to something deeper. And when I say yes to God regarding what God is calling me to do, whether that's being a parent, this 13-year-old girl made the decision to become a parent to Jesus. How powerful is that? With the first IUI, listen, we think that somebody during our time created IUI. The first IUI was created thousands of years ago. And the person that we say that we worship was conceived via the first divine IUI. And if that does not give us permission to walk into our destiny and to walk into our purpose, I don't know what can.
Yeah. So Jennifer, we are having a good time.
I know.
We don't want to leave the audience out.
Everyone's asking great questions. Everyone's concerned if the event is recorded. So you guys are encouraging everyone. Everybody's just so happy that you guys are talking about your personal experience. I'm just going through the questions to see if there's anything that stood out. A lot of concerns about age to see if they're on the cusp or if it's too late. It's not too late. So you
It's
guys
never too late.
Exactly.
Come on in, get advice. Just start with the fertility assessment.
Right.
Somebody is asking about the dauntingness of the IVF process. And they said it can be daunting mentally and physically and exhausting.
Yes.
They said they're trying to prepare for it. So can we talk a little bit about how people can prepare for the services or receiving treatment mentally, spiritually, as well as physically? Can we talk a little bit about that for them?
I usually encourage individuals or couples who are about to embark on their journey of IVF to talk with other individuals or couples who've already gone through the process so that they get a good sense of what they're about to undertake. I find that I have a lot of patients who are really receptive to sharing their own experiences, and whether they're failed IVF outcomes or success stories. I can't stress enough how many people are willing to share their own experiences.
It is, you know, my car broke down on the way to one of my infertility appointments, and I didn't know what to do. I started to cry because this malfunctioning car was gonna define the rest of my life. Now, it didn't happen, right? But that's the level of my angst, my stress, my worry that it wasn't going to work, that I had waited too long, and, you know, all of those thoughts that go through your mind. So I want to acknowledge that, you know, I had one IUI followed by which failed, and then one IVF which worked. But it's scary, and it is stressful. And then in the midst of all that, you know, again, you're worrying about insurance coverage. At the time I lived in New Jersey, and they have the family building law. So I was aided by that mandate in terms of getting coverage from my health insurance. So, but it was cumbersome, you know, getting the information, getting someone to help you. And I think for me, I was very transparent with my family, with my mom. And so I had the emotional support to sort of hold my hand through this process. And so my mom, who's very conservative, she was so worried. She was like, oh my God, you're not gonna have a baby. This is horrible. It's the worst thing that could possibly happen. And that's a different conversation. Right? I'm going to just say that. But even my mom, who's a very sort of conservative person, was sort of on board with, you know, let's have this grandbaby. Let's get chop. Let's get going. You know.
I have one question, panelist.
May I just add one real quick,
Sure.
Just a shameless plug. People are talking about books and also support and other things that can help them to prepare. I invite you to check out the book, Hold On to Hope, Stories of Black Women's Fertility, Faith, and Fight to Become Mothers. It has 28 stories of Black women who have struggled with infertility or who are struggling, who also took different paths to fertility. And they talk about all of this as far as what they had to do to prepare, what they went through, and just some of the basic practices and tips that they learned as they went through. And I encourage you to pick up. All of them everybody dealt with different types of fertility challenges as well. We have a lot of information from both doctors as well as persons of faith, and it will help you. And so I ask that you check out my website at drstacyedwardsdunn.com. I've also placed it in the chat. Most people, and even doctors that have read it and has stated that it's one of the greatest resources for women of African descent and people of all ethnicities. It will help you. So I want to make sure that you get a copy of the book. It will bless you and be a great resource and a comfort for you as you walk your journey.
Great. Thank you for that. I have a question that I do want to present to the panel. Question states, what can we do on a larger scale to change the narrative around Black fertility? What do you think that we can do?
I think, I think to circle back to comments that were made around this issue earlier in this conversation, I think we need to be educated, the community, Black women, because we are culprits in terms of spreading this narrative. We do it. I mean, I've heard it, I've seen it. And in the sense that, there are larger things that need to be done, media, these types of panels and having more of them, I think we first need to really educate the community, the Black community, about the risks and about the problem, because people don't believe that it's there. Right?
Awesome.
Yeah, I think that you hit it on the head. I think that we have to continue to break the silence. We got to move beyond the shame and continue.
Reverend Stacey, I know you're someone.
Can you hear me?
Yes.
I said same thing as Dr. Nevins just stated, that we just have to continue to break the silence and move beyond the walls of silence and shame. And every time we get the opportunity to have these types of conversations, or even one-on-one sister girl conversations, we have to continue to have it and not be shamed about it, because most of us would be amazed how many people are struggling with fertility challenges or just trying to make a decision about what they're going to do about their reproductive health, or even becoming a parent or not becoming a parent. And so again, we have to work together and continue to collaborate and communicate so that we can continue to make strides around this.
Mm-hmm. Great. Just looking here. We're getting a lot of great feedback. Thanking you guys for your information. There's no other outstanding questions. Any thoughts on acupuncture while doing IVF?
Yes.
Are there any benefits towards that?
Again, we talked earlier about mental health playing a big part in or contributing to infertility. I'm all for acupuncture. I think it's most helpful around the time of implantation when you're getting ready to do an embryo transfer. But I think it's useful even before that. And anything that you can do while you're going through this process of trying to conceive to reduce stress, I'm all for. So I'm all for acupuncture.
Me too. Somebody is asking about BMI and why is it important, particularly for African American women?
So we know that in obese women, they can have very irregular menstrual cycles just because of obesity itself. They're also at greater risk for miscarriages. And so sometimes if you just encourage obese women to lose just 5 to 10% of their body weight, you can actually resume normal menstrual cycles, which can help you conceive because you have to ovulate in order to get pregnant. And it can also lower your chances of miscarrying. So weight does play a big part. We're talking about, at the other end, there are extremes of weight, being underweight. That also can prevent you from getting pregnant until you put on enough body mass to resume normal menstrual cycles. So weight overall plays a big part in our ability to get pregnant.
Definitely.
So there's a question that just floated by that I wanted to address, and that is about my comment earlier around this tendency of services, government services that are designed to prevent pregnancy and not facilitate them. And what I was referring to is similar somewhat to the Tuskegee, in that in the late 60s and 70s, there was a whole issue with illegal sterilization of poor women. So it's in the history books, and a lot of people may not be aware of it. And so because of that, that was outlawed. And now if someone wants to get a tubal ligation, there's a whole host of paperwork, right, Dr. Nicole?
That is very true.
Evidence, we have to go through this. That has to be signed while she's at the office, right before you do the surgery, just to make sure there's no coercion at all, and more importantly, to make sure that there's informed consent, that the patient knows exactly what's going to happen. And I always use, the movie star scenario. You meet the movie star of your dreams. He's gorgeous. He has billions of dollars. Would you want to have another baby? Right? And if the answer is still no, then I'll go ahead and tie your shoes.
That's
right?
fair. That's fair.
Right? So that was an issue. And these types of institutional mandates, they don't disappear once the law changes, right? They tend to linger in the room, like food, cooking, the smell of food after you've already eaten the meal. And so it still very much affects how people proceed in terms of contraception. With respect to contraception, even though we moved away from definitive, that final tie your tubes, cut and burn them, there's still a concern that there's coercion of, certain women, African American and other minorities, in terms of IUIs, birth control pills, that they're offered those services more than their white counterparts. So again, the stereotypes, the institutional barriers, the language that's presented to patients, it all stems from things that were considered legal that happened, 30 to 50 years ago, that we still have to navigate and protect against from happening today.
Very cool. Last question. This is regarding the grant. We've received it several times. Several participants in the chat have asked about the lab submission. So to apply for the grant, you have to submit lab results and a personal statement. The lab results that they want to that they have to submit, they just want clarification, and I just want to make sure, is it the standard panel that you have to submit?
Yes, the standard panel, and anything else. If they only have a standard panel, to submit that, and any other labs that they may have beyond the standard panel, we would want to see as well, so that the doctors and the persons that are on the committee might be able to review the application appropriately.
Okay, so everybody, you got that standard panel, and you're good to go, and your personal statement. All right. So we're going to wrap up the question and answer segment, and I'm going to give each panelist a few minutes just to offer any final words, anything that they'd want to state to our participants, and then we're going to close up. Starting with Dr. Nevins first.
Okay. You know, my comments stem from what I've learned in the study of population health, but more so from my personal journey. And I'm happy that we've had so many participants on this chat. I'm happy that people are thinking about what they want to do and seeking information, seeking knowledge around their reproductive health. And this is why I started belowthebellybutton.com. You know, you need to understand what's happening, understand your choices, and understand your resources so that you can plan for your life and that you're not caught off guard. And so, you know, I hope to have more of these chats. I certainly appreciated being a part of this esteemed group, knowledgeable, passionate women to present information on the topic of Black infertility. So thank you for the opportunity.
Great. Next, I'm going to have Dr. Brown offer her final statements.
Right. You know, this came up during our discussion. If you're questioning whether you need to seek help, come on in. Don't wait. As Reverend Stacey said, we want no regrets here. We can't go back in time. And we want to make sure that you have all options available to you. But the longer you wait to come in, so those options start to dwindle, okay? We're here for you. I love the fact that we did this event today. It's needed, and more events like this, I hope, are underway.
Thank you so much. Lastly, we have Reverend Stacey. Reverend Stacey, can you hear me?
Can you hear me now?
Perfect.
Yes.
All right. Again, I want to thank Kindbody for the opportunity to be a part of this esteemed panel and this discussion. And we want to thank everyone for joining us today. And we just want to continue to encourage each one of you all who are a part today and remind you that you are not alone, and to take charge of your own fertility and reproductive health, and get the support that you need to move forward, whether that is to preserve your fertility or even to build your families. If you need anything I know from Kindbody that they're there, but if you need anything from Fertility for Colored Girls, we invite you to check us out, become a part of our movement as we are seeking to change and impact the world regarding this issue of Black women and reproductive health and infertility, because we really believe that Black fertility matters. And so join our movement and help us to impact change. Check us out on Facebook, check us out and follow us on Instagram. Make sure if you need the resources that you try to apply for the grant. But whatever you need, please know that we are here to support you. And whatever you do, don't give up hope. And know that there's a plan for you and a path for you. I look forward to hearing from you real soon.
Thank you so much. So in closing, I just want to say thank you for everybody for coming to this event today. It was a great experience. And like I said, it was a safe space. So everything that you shared with us, we really appreciate it. This isn't the last time that we'll have an event like this. So just keep an eye out. Follow us on Instagram, Facebook. Watch our website as well, because we will keep you updated. Once again, the promo code is BFM 2020. If you have any questions about the services that we offer, you can always check our website or email us, the customer success team, at navigator@kindbody.com, and we will be happy to help you. We're here to help you through everything that you're going through, and we'll take it one step at a time. But other than that, we're going to close out the event, and you can always reach out to us. Thank you for attending. We'll see you soon.
Jennifer, thank you very much. You were a wonderful moderator.
Thank you, Jennifer.
Yes, Jennifer.